Hello, my name is Daniel Kwon. I'm a radiology resident at the University of Ottawa, and I'm one of the trainee editors of Radiology Imaging Cancer. I'm pleased to be the host of today's Radiology Imaging Cancer podcast today on the topic of state of the art on nuclear medicine and oncology. Joining me to discuss this topic today is Dr. Peter Choyke. Dr. Choyke, welcome to the podcast.
Great. Thanks for inviting me.
We really couldn't have picked a better guest to discuss this topic today. Dr. Peter Choyke is a radiologist and chief of the molecular imaging branch at the National Cancer Institute. He obtained his MD from Jefferson Medical College and finished his radiology residency at Yale University and fellowship at the University of Pennsylvania. He's an accomplished researcher in multiple areas of imaging. Dr. Choyke is particularly focused on advancing novel molecular imaging probes, including radiopharmaceuticals, for the clinical translation in oncology. He helped advance multiple clinical trials of PSMA targeting radiopharmaceuticals for PET imaging of prostate cancers. He has received multiple awards for his work, including being elected to the National Academy of Medicine. To begin this conversation, Dr. Peter Choyke, nuclear medicine has experienced such a huge uptick in the number of advances. The specialty was predominantly known for cancer staging using FDG and bone scans, some thyroid imaging and treatments, and some more, niche applications. When I was in medical school, radiologists used to joke that nuclear medicine was unclear medicine. But now, with the advent of tracers that not only image targets like prostate specific membrane antigen, or PSMA for short, but really do so at very high sensitivity and specificity, nuclear medicine is really entering into its window of prominence for diagnostics. In your experience in the last few years since the advent of PSMA imaging, let's say, how has this transformed how we image and diagnose patients with prostate cancer?
Well, PSMA has been a real game changer and also sort of an example of what we can achieve in nuclear medicine with very specific probes and good imaging technology. So prior to that, we were focused on CT and bone scan for staging. And with the incredible sensitivity of PSMA, it's just unveiled a completely new disease in essence. There was a, there was a period where patients would undergo prostatectomy, their PSA would be rising, but their imaging was completely negative. It was sort of a no man's zone, where patients suspected they had recurrent cancer but couldn't be sure. And now we have the ability to not only document that it exists, but where it exists and potentially treat it early. So it's really been a game changer. And it's just at its beginning. I mean, we're just beginning to see how it's going to be used. It's going to be used for early staging, triaging patients to either surgery or radiation. It might even be used someday for diagnosis. It's certainly going to be used in the monitoring of patients on therapy. And then, of course, PSMA based therapies are a whole new thing.
So, for the benefit of our audience who may not be 100% familiar with PSMA imaging, what are the current key indications for PSMA imaging in patients with prostate cancer?
Okay, so the FDA approved indications are patients at high risk for metastatic disease at diagnosis based on high PSA and high Gleason score, and for recurrent disease after definitive therapy, that is either radiation or surgery with rising PSA. So those are the two, approved indications. But as you know, once something is introduced into the ecosystem of medicine, other applications start to develop.
And do you have an example of an exciting application of PSMA PET imaging that really, excites you as we sort of continue these trials and assessment of PSMA in clinical oncology today?
Well, the one that intrigues me the most is using PSMA earlier to in the diagnosis. Currently the paradigm is to do an MRI and then direct a needle into the MRI positive lesion based on its PIRAD score. But if you compare the PSMA and the PIRADS lesion, oftentimes they don't exactly overlap with each other. And it's sort of intriguing to think that you could biopsy based on the PSMA and perhaps get to the the highest grade tumor that exists in the patient right away. In some cases where there's a very large tumor and a very high PSA, there's a question about whether you really need to do a biopsy at that point. I mean, is the PSMA sufficient to guide further therapy? And, those are really intriguing to me. I think the story on metastatic disease is a little bit more confusing, to be honest. And we need more time to figure out what this scan is trying to tell us about progression and ways to intervene.
And that's a perfect segue into the next question that I had is in terms of the impact of PSMA imaging for our colleagues in urology and radiation and medical oncology. A lot of these studies have shown that it increases the upstaging of patients' diseases. The current standard of care is based on trial evidence using CT and bone scans to detect oligometastatic cancer, etc. So, without this up to date evidence using PSMA imaging, how do our colleagues synthesize PSMA imaging results into their own clinical decision making to treat their patients or not?
Daniel, that is the number one question. I guess all new technologies undergo this kind of evolution where it's introduced and it's the best thing ever. Nothing could be better. And they make all kinds of clinical decisions. And we've seen decisions being made on SUV on a PSMA scan going up by 10 units. And like, what are we doing? We don't know what a significant change in SUV is. We don't even know what that means. The existing data based on CT and bone scan has over 30 years of experience, and we kind of know what it all means. But into that, we're introducing this new biomarker. Its presence is way ahead of the knowledge that we have about how to use it. And so I see some doctors use it in a very conservative way, sort of trying to draw on their 30-year experience with bone scan and CT. And then I see other clinicians just saying, well, this is the gospel truth, and we're going to get ahead of this. And, in a disease that can be 10 to 15 years in duration, it's not at all clear that we're doing patients favors by intervening early, at least in the ways that we intervene early today. There may be new therapies that are developed around the early diagnosis of a recurrent disease that make more sense, but very intense androgen deprivation therapy has its consequences. And, patients are being placed on that earlier and earlier as a consequence of the PSMA scan. And it's not at all clear that's going to result in better outcomes. So we have to do a lot of work in that area.
In terms of whenever there's an advent of new diagnostics, back to your point, there's always also the risk of lead time bias in that we think we're having an actual benefit for our patients, whereas we're just merely detecting the disease earlier doesn't translate into increased survival. Do you think that's a huge risk with PSMA imaging in patients with prostate cancer?
It's a definite risk. I mean, because the natural history of prostate cancer is very long. And there are people who wait to the last possible minute to add therapy to it. And those patients do pretty well. And so just seeing the disease earlier doesn't necessarily mean you need to treat it earlier, just for the reason you said, that we don't really understand the natural history of the disease at its pre-CT or bone scan appearance stage. That could be a very long time before it becomes evident. So, we're being cautious. At least several of our clinicians are agreeing to be cautious and just waiting and seeing what happens without necessarily intervening on early PSMA recurrences and things like that.
Of course. And another, I guess, a concern that radiologists and clinicians may have regarding PSA imaging is that while the name says that it's specific, it can actually manifest in other benign causes, inflammation and other benign etiologies. In your experience in reading all these PSMA PET scans, do you think that there's a set guideline or a method in being able to detect whether something is a potential recurrence versus something that's more benign, so that we don't overtreat our patients?
Yeah, I mean, that's another area that's evolving. We do know some reliable pitfalls like the posterior ganglion lighting up and benign tumors that light up, granulomas, sarcoidosis. There are a lot of false positives that we know. But probably the more common thing is, a very poor uptake lesion, one in a bone or a lung or someplace that. And, there you have to invoke some, common sense about what the Bayesian probability that that's a metastasis. I mean, we do this all the time in everything radiologists and nuclear medicine physicians do. We adjudicate how risky a lesion is. And just because PSMA is a new agent, and just because its name implies that it's specific, doesn't mean that you have to call every lesion you see as metastatic disease. And we actually studied the incidental, what we termed incidental solitary bone lesions in the pelvis. And they were quite common and almost always, I think 1 out of 50 proved to be a metastasis. So almost all of them are benign. And it's a common sense stance, right? One lesion, not very meaningful. 10 lesions, very meaningful, right? So, I don't think we have to jump on every single lesion. We have to appraise its uptake, its size. By the way, keeping in mind that small sized lesions can vary greatly in SUV depending on what machine you're on. So, small voxel detector system can make that SUV much higher than a large voxel older system. Same lesion. So you have to be, careful about what machine you're doing it on and technical factors. But in general, since that's so complicated, common sense is the thing you need to introduce.
So we focused a lot on the imaging sides and the advances and potential pitfalls of PSMA. And I know that this is a radiology imaging cancer podcast, but I just want to quickly move into the field of radiotherapy. There's an incredible amount of interest in theranostics and PSMA. There's a lot of exciting new trial data like the Vision trials and the subsequent FDA approval for lutetium 177, PSMA 617, or Pluvicto. Could you explain to our audience briefly what theranostics is and where do we stand on treating prostate cancers with PSMA targeted radioligand therapy?
Yeah, great question, Daniel. So the way we image a cancer is we have a ligand to which we attach a radioisotope, and then we image it, say on a PET scan. But you can replace that diagnostic isotope with a therapeutic isotope, one that emits beta particles or alpha particles, and thereby direct the therapy to the cancer itself. Of course, that's the beautiful concept. The actuality is not so simple because oftentimes the best imaging agent is not necessarily the best therapy agent. Another potential issue is that not all the therapeutic isotope goes only to the tumor. It can go to other organs, like the bone marrow in particular, or the salivary glands. PSMA 617 or Pluvicto has had dramatic impact in the treatment of prostate cancer. Several trials, the Vision trial and PSMA-4 trial, showed at least 4-month survival benefits in patients with considerable quality of life improvements. And I think at minimal side effects. I mean, not no side effects, but generally grade 1 or 2 adverse events, occasional grade 3, 4. And most of it was sort of dry mouth or asthenia, weakness, fatigue, that kind of thing. So, probably more important than the extension of life is the dramatic improvement in quality of life that many patients enjoyed, at least for months after receiving even only one dose of the agent. And that just really woke medical oncologists up to the idea that this is a really amazing drug. It's unusual for them to get such a dramatic response with so few side effects. So they're completely on board. It is a sort of best case scenario in that PSMA is very highly expressed in prostate cancers. And so it's ideal in that point of view. It's also an internalizing receptor. So once the PSMA binds, it goes inside the cell where it's going to be more destructive. So that's important. If you dissect out the VISION trial, most of the benefits occurred in a minority of patients who were very high expressing PSMA. So if the SUVs were greater than 12, those patients got very dramatic responses. But if the PSMA uptake SUV was lower than that, the results were not that great. And so, we have to take that early experience and look at it more carefully. It is possible that if the patient presents with a very high PSMA uptake, Pluvicto will be very satisfactory treatment for that individual, and they may get very long duration result. The majority of patients who don't express as highly may require additional therapies, adjuvant therapies to the Pluvicto to get extended benefits.
Fantastic. So, just on the topic of these new radiopharmaceuticals that have the potential to treat patient cancer. So, PSMA isn't the first radiopharmaceutical to be used for this case for indications such as this. So, in the past, there have been other radioimmunoconjugates such as Zevalin, which was used for certain types of lymphoma. But while the use of Zevalin is significantly low, if not non-existent at this point, there's an increasing number of patients being treated with lutetium-177 PSMA. What is the difference between this agent versus what's come before?
Well, the primary difference is that prostate cancer is so common, and the late stage of prostate cancer is so miserable because of the bone pain of metastasis. So that combination of a great targeting agent, a very common disease for which very little could be done, it's just the perfect storm for PSMA. But you're quite right. Now, so thyroid cancer has been treated with I-131 for decades, very successfully, and doesn't get much press. It's not that common a cancer, but it's certainly very, very important arrow in the quiver of treating cancer. And for neuroendocrine tumors, Lutathera has been very successful, but it's a very uncommon cancer in comparison. Zevalin in lymphoma was competing with enormous numbers of new biologic therapies that were coming out at the same time. And I recall even my own oncologists were like, why do I need Zevalin when I have 25 other things I could do for these patients? So it was coming into a much more competitive environment where there was much better success in treating the cancer. As I look into the future, do we have that many examples of successful cancer therapies where we can say, yeah, we're done with that. We don't need anything more? Very few, as a matter of fact. So I really think the future is much more optimistic than our prior experience might indicate. As we get into, I think breast cancer, what about that? Lung cancer, metastatic colon cancer, hepatocellular carcinoma, GYN malignancies. I mean, we all know that these do not have great solutions for the metastatic setting. And if we can get directed therapies that can get sufficient dose to the tumor to kill it without causing serious side effects to the rest of the body, then this is going to be a very important leg of the treatment platform for cancers. Right now, we have to acknowledge that we're at the low end of the dosing curve when we give these radionuclides. And that's pretty much purposeful to avoid the side effects. They were designed to be low adverse event agents, just at the sort of lowest part of the dose response curve. if we're going to move towards, more effective therapies, we're going to have to go up that dosing curve, which using current strategies might not be acceptable, to be honest, because we've sort of sold it as a low side effect treatment. But there are all kinds of great ideas about how to get more dose to the tumor with fewer side effects to other organs. And I'm thinking here principally of the pre targeting strategies, where you come in with your targeting agent first, unrelated to the radionuclide, and then you're able to attach many more radionuclides to that pre targeted so that you can get 4 or 5 fold dose to the tumor without 4 or 5 dose to the bone marrow. And now, with a strategy like that, we can think about at least sustained benefits or cure. I mean, that's not out of the picture. I'm also intrigued by the idea of combining our agents with external beam therapies as well, to have real time PET guided external beam therapies, a technology that is now, available. And it's intriguing to think about using EBRT for metastatic disease.
Thanks for that very insightful answer. Just quickly, while we're still on the topic of PSMA, there are several imaging agents on the market currently. There's a number of other PSMA radiopharmaceuticals in clinical trials for both imaging and also for treatment. What's the state of the art on other agents such as PSMA INT, and how do they really fit in with the current landscape of approved PSMA radiopharmaceuticals?
Well, in the US, we have only one approved therapy agent, two approved diagnostic agents for PSMA. In Europe, PSMA INT is used in some countries. The I is imaging and the T is therapy. So, in theory, that's a one stop shop. You can do imaging with it and you can do therapy. But if you look at places that do it, and we don't do it, they often use a separate imaging agent altogether from the INT. And then the therapy, as far as we can tell, the trials are much smaller than with PSMA 617, but the results seem comparable. And there's no reason to think that it's either dramatically better or dramatically worse than PSMA 617. So, of course, we welcome more players into the market to add a little competition and make the supply chain more robust. Alternatives, if something goes wrong with one company, you can switch to another company. That's very, very useful. So we should welcome all new entrants into the field. And, there's a lot of, I think Novartis made almost $2 billion last year on their PSMA portfolio. So, that's attracted a lot of attention to this field. Hopefully that will rejuvenate a lot of the isotope manufacturers and companies that put these things together and deliver them to hospitals. There's a whole supply chain infrastructure that needs to happen. And there's nothing like a little incentive to get our system moving. And that's exactly where we are right now.
And just lastly, there's a lot of excitement with alpha emitters as opposed to beta emitters such as lutetium 177. There's already an approved radiopharmaceutical, radium 223, that's used for bone metastases and prostate cancers. And now there's a lot of efforts moving towards actinium 225, combining it with PSMA targeting agents. Do you think that this is going to be a game changer in terms of its efficacy as compared to that of lutetium 177, or should our clinician colleagues temper their expectations with respect to the efficacy of these newer agents?
Well, there's a big problem with alpha, and that is that it's 3 to 4 times more effective than beta. And so every event is very significant. So that should be good for treating cancer, but it's also, an equal problem for the non-target organs, and in particular, the salivary gland, which if you've done a PSMA scan, you know that the uptake in the salivary glands can be just tremendous. So the experience has been that actinium results in very severe salivary gland dysfunction, xerostomia, and not the mild xerostomia that we see with PSMA 617, but severe, irreversible. And that has just a significant downstream problems. I mean, dentition is terrible, taste goes away. Talk about quality of life. I mean, it really ruins the quality of life. So, there was great enthusiasm for lutetium. And then we heard a lot about actinium. And of course, on the articles, you would see the arrows pointing to the salivary glands and saying, see how the salivary glands don't light up anymore? Well, that's because they're dead. And that's severe xerostomia. And, that has really slowed down the field because you can't be doing that. That's unacceptable side effects. Now, there's some really exciting work out recently that there's a potential way to block that uptake in the salivary gland because it turns out that it's not actually PSMA expression in the salivary glands. It's a related molecule, and it might be possible to block that uptake without blocking the cancer uptake. And if that's possible, then yeah, we're back in business. And alphas are going to be, coming at you, either actinium or lead 212. There are all kinds of options, and it's going to be a very exciting time. But in order for that to work with PSMA, we have to overcome the salivary gland problem.
Thank you for your insights on PSMA. Moving to another area of imaging, there's a lot of interest in other targets, and one of which is called the fibroblast activated protein, or FAP. And there's been a number of studies looking at PET imaging of FAP expressing cancers that are primarily stromal. Can you walk us through the underlying rationale behind imaging these fibroblasts and some of the most promising indications of FAP directed PET imaging?
Yeah, well, it's very exciting because really for the first time we're directing an imaging agent at not at the tumor, but at a benign cell that's found in the tumor, the fibroblast, the cancer associated fibroblast, which has specific activation of FAP. And there are a number of tumors where fibroblasts are really very proliferative. I'm thinking of pancreas, cholangiocarcinomas, but other cancers as well. And as a result, in head to head comparisons of FAP PET to FDG PET, FAP often is more sensitive for the detection and staging of cancer. So, especially exciting to me is pancreas and the cholangios, which can be hard to really detect with conventional imaging modalities. So it's possible that we could detect them earlier with these kind of PET scans, especially in combination with liquid biopsies like cell-free DNA studies, which are coming out every day. There are new, screening serum screening tests, and they're great and very sensitive, but they're going to need an imaging agent to go along with them to find out where the tumor actually is. So I'm very excited about all that. And, it remains to be seen whether it will replace FDG. I don't think it will, because not all tumors are stromogenic in the same way. But for collection of cancers, it's going to be, and I would include ovarian cancer in that, could be really a game changer in terms of sensitivity of staging, which would bring us back to one of our original points about lead time bias. But you can't argue with more sensitive staging techniques, especially with aggressive cancers. Now, because they're not tumor antigens, but antigens associated with a benign cell, targeting them for therapy is an open question. And so far, the results have been equivocal at best. There's certainly no home runs using treatment paradigms with FAP.
So you brought up the point of how potentially FDG may or may not be displaced by FAP PET imaging, and that given the likely different indications for these two imaging agents, that both will continue to be a mainstay in oncologic staging and imaging. With these new agents coming out and other new agents being evaluated in clinical trials, how do we efficiently deliver these radio tracers to patients logistically, given that PET imaging volumes are increasing every year, not just in the United States, but across the world? Do you have any sort of insight into how we might make this more efficient or and deliver this imaging paradigm to our patients?
You know, I don't really have great concerns about it. Our ability to adjust to the new reality that there are going to be different agents for different things. I think we can educate our physicians pretty quickly. I mean, I think we can probably have some AI that watches the whole thing and might suggest, this would be a better type of scan than the other. The one area that we encountered now that we're doing all these different scans is that sometimes they get mislabeled just by accident. And it used to be it was just FDG PET. There was no other option, so it didn't matter what it was labeled. But now with PSMA and FAP and CXCR4 and all these agents, so we're actually thinking about a quality assurance algorithm that would just have a quick check and make sure that the name is correct with the image. But I think doctors are very adaptive to new technologies and knowing what to order for what indications. They're very smart about that, and I'm not that concerned that we're going to have a big confused mess. We'll have a little mess, but not a huge mess.
Jumping on to your previous answer, you mentioned CXCR4 or CXC chemokine receptor 4 as a potential another target or antigen for molecular imaging. I do need to disclose that I myself have intellectual property regarding molecular agents targeting CXCR4 and personal consulting fees regarding this area. I wanted to ask you, in your experience, where do you see CXCR4 PET imaging going, and for what are its potential indications?
Well, in oncology, certainly, lymphomas and myelomas are look like it's going to be very good for that, especially, bone marrow niche type tumors in general. I think it'll be good. The area we're starting a trial in is in hyperfunctional adrenal glands like aldosteronoma and Cushing's syndrome, and where some very clever, observant doctors in Shanghai found that there was uptake of CXR4 in functional adrenal masses. Since our docs struggle so much with these adrenal vein samplings that are very technically challenging, it's possible that we could replace all that. So, again, it's a niche application. Aldosterenomas and Cushing's adenomas are not that common, but adrenal adenomas sure are. And if there was a easy way to determine whether it was a functional adenoma or not, that would be, I think, a very useful test. One area in particular is CNS lymphomas because FDG is not that useful in the brain because there's a lot of uptake naturally. So it's hard to stage in the brain. So CNS lymphoma is another niche application for CXCR4. There are others. I mean, adrenal carcinoma, again, a rare cancer, but it seemed very well suited to CXCR4. The agent that we work with is called Pentixifor from a company called Pentixapharm, and it looks like it's going to be very successful in that tumor as well. So there are all kinds of things to discover. It's going to be a very, very exciting future with many, many new agents, many new companies, and I just think it's going to be very exciting for young imagers to get involved in and see where it goes over the next decades. The future is incredibly bright, and there are all kinds of ways to go, all kinds of directions, all kinds of new technologies, new platform technologies like nanobodies and things like that to be explored. So I would encourage anybody who's interested in, trying to figure out what they want to do that would be interesting in imaging. I would highly recommend nuclear medicine right now. I've heard it described, this is not original, but that nuclear medicine is undergoing a Cambrian explosion, which I think is a really apt description of what's going on now.
Thank you so much for your insights, Dr. Choyke. Just to conclude the podcast, You mentioned the Cambrian explosion of discoveries in our field today. Do you have one that we didn't discuss on this podcast that you're particularly excited about, whether it's a new imaging agent or an application of an imaging agent that you'd like to discuss?
Well, in general, I think multiple myeloma is a disease that's been underserved by imaging. That's beginning to change, and I think it's going to completely revolutionize the way we think about myeloma. I think our current concept is that it's a diffuse disease, and that is because we're catching it at a time where it's widely metastatic. But it starts probably with one lesion or maybe just a couple lesions. And I think if we can, through a combination of liquid biomarkers, which are readily available now for multiple myeloma, and judicious use of imaging, we could catch it at a much earlier stage. And I will say another thing that has deep parallels to prostate cancer is that when we first got started in prostate cancer imaging, it was standard of care to put 6 or 12 needles into the prostate, regardless of anything. It's just going to be 6 on one side and 6 on the other, blind biopsies. What do the multiple myeloma docs do? They put a needle into the posterior iliac crest for their bone marrow biopsy. Well, the disease isn't always there. I mean, the disease can be elsewhere early on. Of course, when it becomes diffuse, it will be in there, but early on, it's not necessarily there. And our biopsies may need to be directed to other bone. And then we'll be dealing with a disease at its earlier stages. And I think it'll be, a completely different ballgame. So I really think that's just the tip of the iceberg, really. I mean, almost every cancer that you can become interested in has a similar story. And, there are things that we're doing today because we don't have the good imaging tools that if we had those tools, it would change the game. And, that's why it's just so exciting.
It really is an exciting time to be in nuclear medicine today. I want to thank Dr. Choyke for joining us on our podcast and sharing his compelling and comprehensive thoughts on nuclear medicine today. I want to thank the audience and thank each and every one of you for listening in. Until next time.